So Dr. Wein, we're here in the outpatient surgery center. We can see outpatient recovery room beds. We hear the alarms going off as patients are cared for around us. So it's actually a perfect area to talk about patients and what they should be thinking about if they have prostate cancer. As you and I have talked about, of the big cancers, the common cancers, prostate is somewhat unique in that not everyone absolutely must consider treatment. Is that right?
That's correct, and that's a very big difference that patients need to understand. It's not like colon cancer, it's not like lung cancer, it's not like pancreatic cancer where you see something abnormal, you excise it. You know, there are a lot of prostate cancers that do not need to be treated.
Patients might just say, I have cancer, why wouldn't I have you remove it? What would you say to me if I'm a patient saying, don't I need to get rid of my cancer?
Well, there are many prostate cancers that are destined not to hurt anyone. And there are certain criteria that you use when you suggest to a patient that they may want to go on a program that we call active surveillance. Active surveillance is like a bet, the way I describe it to them. You're betting that using this program, the tumor is either not going to progress, or if it does progress, you will catch it before it progresses to a state where it's less curable than it is now.
So do you offer active surveillance to every patient whose biopsy comes back for cancer? Or what do you say to the patient in guiding them?
They need to have minimal disease that under the microscope does not look terribly aggressive, and they have to have a PSA that's relatively low. Most people say less than 10.
So these are really evidence-based criteria that help you decide if you can offer me, the patient, active surveillance, or if you would suggest we really need to go ahead and try to address this right now.
Based on experience of a lot of people, that using those criteria, that you're in a pretty good position to win that bet. It may progress, but if it does, you will catch it before it progresses to a state that it's less curable.
Now, if a patient either decides to have active surveillance and the disease progresses, or they meet that evidence-based criteria where treatment is indicated, is surgery the only option? Is it the best option?
No, well, it depends what you mean by the best option. For localized disease that's confined inside the prostate, if you're talking about cure, what I tell the patients is, look, if you're asking me what I think the best cure for what you have is, that is total absence of disease, I think it's surgery. If you're asking me what the best treatment is for you as an individual, only you can answer that after you hear the pros and cons of surgery and radiation. It's our practice here generally to have the patient see radiation oncology as well. Let the radiation oncologist tell the patient what they have to offer, what they think. We'll tell them what we have to offer, what we think, and then let the patient sit for a while and make a decision. I tell the patients, never decide in the doctor's office. Always go home and think about it, and then you'll come to the right decision.
Patients hear so much information about prostate cancer. A third of men will get it, and some should be treated and some shouldn't. How common is it, and how often do we really need to treat men who actually have prostate cancer?
Conceptually, it's a little difficult to understand for someone that hasn't heard it before. So your chance and my chance of being clinically diagnosed with prostate cancer during our lifetime, because of some either elevated PSA, abnormal digital rectal exam, whatever, about 1 in 6. However, if you went down to Penn Station and you took every man over the age of 70, they would find evidence of prostate cancer in well over half of them.
Wow.
A substantial number of people with prostate cancer don't have to be treated. Most of those, however, remain undiagnosed throughout their lifetimes.
Well, it seems like a take-home point there is if you're being screened for prostate cancer and you have an elevated PSA or a finding on your examination, that what's really important here is getting to a urologist, an expert such as yourself, because there are a lot of subtleties to this and a lot of options, and it's not just a cancer I have to go and get treated right away. There's a lot of talking and thinking to do.
It's not a reflex action. You really have to know it, which is why it's best if you're a hard-working primary care provider and you have somebody with this issue, it's best to send them off to someone whose only job is to think about those issues.
you.